Good morning, everybody. Thank you for joining us today. This is session 5 of the Lurie Children's Preventative Pediatric Cardiology Roundtable Series. And we are here with Dr. Erwin Bennick, and he's going to talk about management of the abnormal lipid panel in pediatrics. My name is Chad Worley. I am the physician liaison for Lurie Children's in the city north suburbs, and northwest suburbs. And I'll be moderating today, and I'm encouraging you to ask questions. Type them up in the chat session, Q&A area, raise your hand. But we love an engaging audience. I'd like to remind you that this session, we do not offer CME credits, but we are recording the session, so you can watch it anytime you like. For those of you watching this recording now, I ask you to hit like, subscribe to our channel, and if you have questions, put them in the comment section. We do monitor the comment section, and we can get back to you and get back to Dr. Bennick with your questions. But without further ado, good morning, Dr. Bennick. Thank you for joining us today.
Good morning. It's great to be here this morning, and welcome everybody who is on Zoom with me now and who will be in the future in Zoom. Please ask any questions you want. I love answering questions about lipids and kids. And so let's go ahead and we'll get started.
Yeah, Dr. Bennick, before we get started, let you, so you not only you're part of the Preventive Cardiology Program, but you're also the division head for community-based medicine primary care here at Lurie Children's. Before we get started, can you just tell us a little bit about that division?
Oh, thank you for asking. This is actually the largest division. We have over 500 members. 150 are faculty members who participate in academics and education. And they're all people who are in the community, who are on staff at the Lurie Children's Hospital in various capacities. We have a bunch of leadership positions that we fill, advocacy, and we have a seat at the table at Lurie Children's Hospital to advocate for the kids that we take care of in the community.
That's great. And if somebody is interested in joining the Division of Community-Based Medicine, they can contact you directly?
Absolutely. Contact me through the Division of Community-Based Pediatrics and or through the medical staff office.
Yeah, and if you can't do that, you could always reach out to me, Paula Nowak, or Julie Kalkbrenner, your liaisons in the suburbs. And we talk to Dr. Bennick on a regular basis, so we can definitely get the word out to him. But without further ado, let's get started. I'll go ahead and move these slides. I'll get off camera, and let's get this started.
Great. Okay, so the next slide. Okay, that's just a title slide. Okay, so I'm going to start off with a confession, actually. I'm here today because I lost a bet. This was not a bet with Chad. This was a bet I made with a pediatric cardiologist 35 years ago. A friend of mine who called me, he was a young pediatric cardiologist at the time. I was a young general pediatrician at the time. And he said, I'm working on lipids in children, and I'd like you to help me out and screen some children for high cholesterol. And I said, Sam, I'll bet you kids don't have high cholesterol. And he answered me, and he says, well, maybe they do and maybe they don't. Back in 1990, we really didn't know. But I'll tell you what, if they don't, I'm not going to bug you with this anymore. But if they do, I want you to work with me on this. And I've been paying that bet back ever since. So that's how I got involved in lipids. But lipids really made a lot of sense to me because if you look at risk factors for cardiovascular disease, all the risk factors are there right at the beginning. All the behavioral risk factors, lifestyle, the genetics, which is really important. And if we could do what Dr. Wart said yesterday with primordial prevention and then primary prevention, we could really change the future of people developing cardiovascular disease. I often give a talk to adult cardiologists, and I start off by saying that in pediatric preventive cardiology, if I do my job correctly, I could put 30% of you out of business. And they kind of laugh, and rightfully so. But in reality, all the risk factors are there. And if you can identify them early, we know that you could delay the progression of diseases. You could help shape behavior instead of change behavior. Changing behavior in older people are very difficult, but if you help shape behavior, get children, infants on a healthy lifestyle right from the beginning, it could really go a long way. Next slide, please. So this is kind of what happens to a coronary artery over the course of events. Everybody's born with a pretty clean coronary artery, but especially if you have high cholesterol, um, by 10 years of age, you will have maybe a fatty streak, which isn't so terrible, but that would progress to a plaque and then an occlusive plaque where blood is just not going through the coronary arteries correctly, and eventually the plaque turns into a thrombosis, and that's what causes heart attacks. So this is what we are trying to prevent in preventive cardiology. Next slide. I was fortunate to be on the task force that looked at with the NHLBI, looking at risk factors for cardiovascular diseases. We came up with 14 at the time, but actually there were two more that I added to this, and one is sleep hygiene, and the other one is stress. We're now realizing that sleep hygiene is really important. That fits under the modifiable risk factors. So those include overweight and obesity, nutrition, metabolic syndrome. You can see it on the left part of that slide. In the middle are not modifiable. Unfortunately, you're born with the genes you're born with. As you age, you certainly become more at risk. Gender is a factor. And some people who have inflammatory diseases like rheumatoid arthritis, dermatomyositis are certainly, again, more at risk for coronary artery disease. And then there's a mixed group. Some people, unfortunately, have type 1 diabetes, but of course, we're seeing a lot more type 2 diabetes in our population. Lipids, some lipids are modifiable, others are not. Blood pressure, it can be modifiable in many situations, and also the additional one of stress, which I included, that was not mentioned in the NHLBI guidelines. So if you take a look at where cardiovascular diseases and heterozygous familial hypercholesterolemia fits, it's autosomal dominant and inheritance, and it's about in 1 in 200, 1 in 250 in the population. These are various screening that we do in the newborn period, as you well know. When I came into practice, we had just PKU, thyroid, and galactosemia. Now there are about 30 or 40 other diseases that are now screened for. We do not screen at this point for familial hypercholesterolemia. There are studies going on right now about the feasibility of adding this to a newborn screening. Next slide. And these are the lipoproteins that we are looking at right now. It's HDL, which we call good cholesterol, LDL, bad cholesterol, triglycerides, which is another type of fat in the blood, and of course, total cholesterol. And it's interesting, and this is really important, especially for the general pediatricians, which I really emphasize a lot, is that LDL is calculated. It is not directly measured, mostly in the United States. Dr. Friedwald, back in 1968, came up with a calculation. It's LDL cholesterol equals total cholesterol minus HDL cholesterol, which is non-HDL cholesterol, which is what we screen for, which you can hear a little bit more later, minus triglycerides divided by 5, which is the VLDL. So basically, LDL is non-HDL cholesterol minus VLDL cholesterol. This is important because triglycerides have to be fasting. If they're not fasting, as you can see, the triglycerides would be quite elevated. And the way the calculation would work, the LDL would be falsely low. So if triglycerides are not fasting, or if the triglyceride levels are much over 250, we do not, the LDL is not reliable. And this is what a lipoprotein looks like. Consider it to be a package that you're mailing. It has a content, and that's a combination of triglycerol esters and cholesterol esters. And depending on what the lipoprotein is, there's various combinations and percentages of that. Then you need an envelope to send it out, and that's the phospholipids. And then you need an address to where it's going to go. And those are the apolipoproteins that are present on the surface of the lipoprotein. So if you take a look at the next slide, oh, this is just labeling it. Okay, here's the next slide. So they are different sizes and different weights. The VLDL is light and fluffy. It floats to the top of the surface. The LDLs are more dense. And the HDLs, which is cardioprotective, is even a little bit more dense than that. And so chylomicrons and VLDL are very fluffy and light. And if you make a comparison perhaps with matzo balls, my aunt used to make very hard matzo balls, and those are more like your LDL. And my mother used to make fluffy matzo balls, and those are more like your chylomicrons and VLDL. So if you like matzo balls, that's kind of an example or an analogy. Next slide. Okay, this is a pretty busy slide, but it's kind of important. If you know this slide, you know a lot about lipids, lipid metabolism. So when your patient eats that double cheeseburger with fries and all that stuff, it's going to break down in the intestine to chylomicrons. I just mentioned chylomicron as a lipoprotein. It's primarily triglyceride in nature. There's a enzyme that's going to break that down called lipoprotein lipase. We actually had a patient with lipoprotein lipase deficiency years ago, and this patient presented with a triglyceride level in the tens of thousands instead of it should be 100 or less. And this was a 2.5-month-old who actually did quite well after we discovered the problem. It gets broken down further into what we call a chylomicron remnant. It gets absorbed by the liver. The liver repackages it to VLDL, and then it goes to IDL, and then finally your LDL. And depending on how many LDL receptors the liver has, it'll either go to the liver or it'll go to some other place in the body. And unfortunately, that place in the body is usually the coronary arteries and the carotid arteries. HDL has a completely different pathway. It is cardioprotective, and it takes LDL from where it is deposited in the vessels and brings it back to the liver. So it's like having an extra HDL. Next slide. And this is just something you all know. There's bad cholesterol and good cholesterol. And the bad cholesterol, the LDL, clogs up the arteries, causes atherosclerosis. The good cholesterol cleans up those arteries and makes them nice and clean. So when we decided to do universal screening in children, we had to meet a certain criteria, and that criteria was that it had to be relatively easy to perform. It was not expensive. There's no hardship on the patient and family. It was reliable, and there was effective treatment options. Next slide. And so I think you've seen those who've been to this roundtable before. I think you've seen various types of this chart here, but we're looking for total cholesterols of 170 or less. Borderline is 170, 199, and high is considered a total cholesterol of 200. Likewise, LDL cholesterol is less than 110. Borderline is 110 to 129, and greater than 130 is considered high. Non-HDL, very simple calculation. I could even do it. You take your total cholesterol, you subtract your HDL from it, and you get your non-HDL cholesterol. Optimally, that's under 120. Borderline is between 120 and 144, and over 145 is considered high. The only other two categories I want to mention is triglycerides. And as Dr. Batista said yesterday, you want that kind of 100 or less in kids. Maybe 120 would be okay. I don't get too upset with it, but you don't want it at 240, 250, or 300, numbers like that. Your HDL optimally is 45 or greater, borderline 40 to 45, and less than 40 is considered more high risk. Don't worry about the ApoAs and ApoBs. That's a different category. So those are the NHL BI. And if you could just hit it one more time. Good. So we had a patient referred to us because of very high triglycerides. Okay, triglycerides were 909. That wakes me up and keeps me up at night. So we did a total cholesterol. So the total cholesterol was 150. The HDL was 38. The LDL could not be calculated because it was so high. The triglycerides 909, that is off the wall, and the liver functions were normal. That's something that we're going to see right away in our preventive cardiology program. So I asked the mother, let me know, was this done fasting or non-fasting? The mother was totally unsure. And since the child was fasting that morning, I said, I'm sending this child right to the lab right now, and we are going to get a fasting lipid profile. As you can see, the total cholesterol is pretty much unchanged as well as the HDL. But look how much the triglycerides dropped. So that's what a non-fasting triglyceride can do. It could really wake you up and raise that level tremendously. I mean, this is about 20%, the fasting is about 20% of the original non-fasting triglyceride, and the liver functions, again, were both fine. So if you're going to do a lipid profile, it has to be fasting. That's really important, or else we're going to get a high triglyceride level and a low LDL level. Next slide, please. Okay, and I think you saw this with Dr. Baptista yesterday. From 0 to 2 years of age, we generally do not do any lipid screening. Once in a while, we'll have a baby come in who was lipid screened for family history or a lipemic looking blood sample, but usually we do not like to see these children. Between 2 and 8, we will see these children. And again, there are criteria for children to be screened between 2 and 8, but it's very selective screenings. When there's a big family history, or the child has diabetes, or obesity, or hypertension, in those categories, we will screen the child before 9 years of age. And as Dr. Batista said yesterday, that has to be a fasting lipid profile and not just your general screening. So here's where the big controversy came in about universal screening between 9 and 11. So we were a panel of 14 people at the NHLBI developing the guidelines, and we really thought that because of the high incidence of familial hypercholesterolemia as well as other dyslipidemia, it'd be a good idea to start screening between 9 and 11 years of age universally. So again, we had those numbers, less than 120 was considered fine, 120 to 145. Just keep an eye on that, repeat it perhaps in the future. But if it's over 145, those patients should be screened with a fasting lipid profile. And then if the LDLs, I really feel, are above 130, in those cases, we should probably be seeing them. If it's a legitimate LDL, it was done correctly, fasting, with a fairly normal triglyceride level. Okay, on the next slide, you will see between 12 and 18, there's no routine screening. And this is something that actually we figured out at Jones Memorial Hospital in the early 90s, that lipids really are pretty stable until about 11 years of age, 11, 12 years of age. And at that time, children are entering puberty, and they need hormones, and those hormones are derived from cholesterol. So all your estrogens, progesterones, testosterone are all derived from cholesterol. We feel there's what we call the adolescent or pre-puberty dip during that time, where lipids will lower up to 30%, then plateau, and then by 15 or 16 years of age, come back to pre-pubertal levels. So that's why we really don't recommend screening during that time. Of course, people in the preventive cardiology program realize that and know how to interpret that. So if you got a 13 or 14-year-old who was screened, we know how to interpret that. And then again, over 17, if you've never been screened before, if it's been abnormal before, you could re-screen again. Next slide. Okay. So I got some examples of cases. This first one is a hypothetical case. And the next two are real cases. But you are to see one of your patients who is now age 10 for his annual physical exam at 1 p.m. So it's in the afternoon. As the NHLBI guidelines recommend universal non-fasting, non-HDL cholesterol screening between age 9 and 11, you can provide this service in your office as a point of service. Because his mother knows he will be getting his blood drawn today, but also his first HPV vaccine, always big on vaccines and want these kids to be vaccinated on time. She decides to proceed this visit with lunch at his favorite fast food restaurant, and he gobbles down double cheeseburger, medium fries, 20-ounce sugary beverages. He has a great exam and is reluctant but agreeable to getting his shots and blood tests. The point of service lipid analyzer performed in your office does the entire lipid profile, which is meant to be fasting, but this patient, of course, is not fasting. You decide to proceed. Which lab values will be elevated, about the same, or lower? So total cholesterol is really not affected. So that's going to be the same. The triglycerides are going to be greatly elevated in this case. And the HDL will not be, so that's fixed. So that's how we got non-fasting, non-HDL cholesterol. The LDL will be falsely lower than it should be, and the VLDL, which is a precursor to LDL, would be falsely elevated. So that's how we would interpret those numbers with this. So if you have a point of service that does the whole thing, you have to, even though it's hard to disregard the triglycerides and the LDL. Next slide. So this is a real case. Jimmy referred to preventive cardiology after routine screening. 4 months early, had a blood drawn for lipids with a total cholesterol of 286. That's high. Calculated LDL of 199. That's high. HDL is a little bit low at 37. His triglycerides were quite high at 282. The mother thought he might have been fasting. Probably wasn't. Family history is significant. I won't go through every bit of this, but there is family history of high cholesterol and also coronary artery disease with the grandfather. He's still alive at 86, but underwent bypass surgery in his 70s with a valve replacement. There's a maternal uncle reported to be elevated lipids, and there's no history of early MI or sudden death. Past medical history. He had a TNA. He's on a couple medications, and there's no tobacco exposure. By the way, tobacco really wreaks havoc on the endothelium lining of the coronary arteries. So whatever your risk factor is, it like triples if you're using nicotine. He attends school in person, as in the 6th grade, averages 8 to 9 hours of sleep. As I said, sleep has become very important to us. He does a nap. He plays a couple of sports, about 45 minutes of physical activity a day. He just got a cell phone, which is removed from his room at 9 p.m. And something that general pediatricians and I always did was make a rule that says these cell phones have to be out of the bedroom and charged elsewhere by 9 o'clock at night. If they come see us in preventive cardiology and they give me the excuse that they use their cell phone to wake them up in the morning, I actually hand them a battery operated alarm clock. And his recreational screen time now ranges from 3 hours, which is a little bit high, to 10 hours, probably on weekends using that cell phone. Our recommendation is 2 hours of less of recreational screen time. So let's see the next slide. So he's okay. 1% milk. We want our kids on either 1% or fat-free milk. The almond milks and all that are really not milk. He does drink greater than 64 ounces of water a day, consumes occasional juice, but does drink soda pop, diet soda, and he drinks an average of 48 ounces of sports drinks a day, which is a little bit more than we like to see. Breakfast is on the go. Lunch is usually packed from home. Snacks and treats are mostly unhealthy, a lot of chips in that, a lot of cookies. And dinner is usually at home 3 to 4 days a week, and the rest of his fast foods or takeout, and eats on an average of 1 fruit and 1 vegetable a day. Next slide. Physical exam. His BMI is a little bit elevated. It's in the overweight range. Other than that, he's a Tanner stage 2, and the rest of the exam is really normal. Next slide. His total cholesterol here was 254. HDL was 40. LDL was 197. So it does hit that range where we would treat. With a statin, triglycerides now are 84. So as you can see, there's a huge difference between fasting and non-fasting triglycerides. Hemoglobin A1C was 5.8. Lipoprotein A is a newer lipoprotein. It is probably an additional risk factor. It adds to additional clotting, which we want people to clot, but too much lipoprotein A, and they could clot too quickly. And the rest of his labs were all normal. Next slide. So his diagnosis is familial hypercholesterolemia. We made changes to his lifestyle and food choices, and we decided to engage in medical management. In the old days, our first medical management when we started this, and we didn't know a whole lot about statins, was a medication called cholestyramine. It was a bile acid resin. You mix it with water or a little bit of juice. It tasted terrible, and it was good for about a 20% reduction in LDL. But we find that kids are exquisitely responsive to statin medications. We usually start them on 10 milligrams going up to 40 milligrams. And we see a very nice response. Fortunately, over the years, we've monitored kids for at least 30 years now who are on statin medication, and they really don't have very many side effects. Some of the side effects you see in adults, we just don't see in children. And it's a medication, as Dr. Batista said, you could take for a long, long time until something else comes up better. So here is the initiation, LDL of 190. If the LDL is between 160 and 190, and there are other risk factors, we could start a statin after we have an attempted lifestyle changes. And we will even go down to an LDL of 130 with other risk factors. So if this patient's a diabetic and obese and has hypertension, those are enough risk factors that even if your LDL is 130, that it's time to start a statin. Our NHLBI guidelines, we set at 10 years of age, and the AP actually came out with an earlier recommendation, actually at age 8. In some patients, I've really started them even earlier. So the last case I have real quickly is actually was a 5-year-old who was referred to me who just had Kawasaki's disease with no coronary artery disease. His LDL was 171 when I saw him. His father, who was in great shape, had a cardiovascular event in his early 30s requiring stents. This family ate very healthy. Next slide. So at 5 years of age, we continued heart healthy food choices and lifestyle, and our goal was to maintain an LDL less than 160 with him. He was on aspirin originally, and that was stopped. Next slide. At 9 years of age, when we saw him, his LDL was at that time 171, and his other lipids were, except for his total cholesterol, was quite good. Nice HDL, lipoprotein A was normal. And at this time, we decided to start atorvastatin, which used to be called Lipitor, 10 milligrams a night. Best to start these medications at night. They have an extra bang for your buck when you start it at night because the digestion takes place a lot during the night, and they have a little greater effect if you start them at night. Next slide, we could see how well he did. And now total cholesterol is 174 with an LDL of 100. Very active young man, and he has a HDL of 58. HDL is most affected by lifestyle. If you're very active, the HDL goes up. If you're sedentary, the HDL goes down. And we caught his 5-year-old sister, and she has FH also, and we are now monitoring her. And next slide. So I really think that coronary vascular disease is not an adult disease. It's a childhood disease. It really begins in childhood. And if we could identify children, we could create a healthy lifestyle, get them on medication if they need it earlier, and it'll certainly prevent end organ damage. We feel that this might be the first generation whose lifestyle expectancy is less than their parents. And heart healthy food choices, sleep, nicotine abstinence, and active lifestyle play a very important role. And medication, when needed, is safe and effective. Last slide. Here we go. So this is a panda bear in the Chongqing zoo that we took in. I took a picture of this in China in 2008, and he's eating very healthy bamboo sprouts. Thank you.
Thank you. That was great. First of all, I like soft matzo balls. So
Okay. Like my mother, not my aunt. Okay.
um, it's it's amazing because I like a good cheeseburger once in a while, right? And so do my kids. And then you say to yourself, well, I work out, right? I work out. I work out all the time. My kids are active. I'm active. It'll be fine, right? But you know, you can't overdo those. It looks like no matter how hard you work out.
Yeah. Well, you can't overdo it, but we do believe in moderation. So, somebody who has a junk food craving once a week or once every other week, we have no problem with. It's those that are basically eating out fast foods or takeout foods almost every day that will
Yeah,
get that child in trouble.
but it's funny. The first case study of the child that the active kid who played sports and he had maybe ate fast food twice a week or whatever. I mean, you pretty much described every family I know that has a 14 and 8-year-old right now. So it's quite interesting. Because in I bring this up because um, all these you see all these kids in so many sports and activities, and I personally believe some of these kids are overscheduled, including my own. But the first thing you say to yourself is, all right, so we went from school to sport to sport to sport. I got to feed my kid. So what's the easiest thing to do? Get some fast food, right? So all this good stuff we're doing for our kids with being active and stuff like this, we're almost kind of ruining it by putting some junk in their mouth, right?
Well, again, I mean, you have to live in the real world, but there are ways of eating healthy foods on the run. And we have a great dietitian who goes over that with our families, our children or our adolescents who are about to start college. She sits down with them and talks to them how to eat healthy on a college campus. We've all heard of the college uh, 15, where
Yeah.
freshman 15. And that doesn't have to be, you can eat healthy. You just have to be disciplined and you have to be informative. And that's what
Mm-hmm.
our program is trying to do, and to get our kids with dyslipidemia who go to college eating
Mm-hmm.
healthy and just making substitutes. We don't hit them over the head on the first day. I mean, you just can't. There are 27 lifestyle changes that I've counted that you can make. But if you could
Mm-hmm.
go after the low-hanging fruit, like sugary beverages is a huge one.
Right.
Um,
Right. I mean, get them out of there, right? I mean, yeah, that's
yeah.
that's I hear that. You brought up the program a little bit. How rare is a program like the Preventive Cardiology Program here at Lurie Children's? Yet I haven't, you know, I'm in this world, and I don't hear a lot of other hospitals offering something like this. It sounds like we're on the cutting edge a little bit here at Lurie Children's on this program.
35 years ago, when we started, we were really on the cutting edge. People thought we were crazy to start this program, but it's caught up. There are more than you think around the country. I don't know many more in the Chicagoland area, but ours is very comprehensive now. We have a dietitian who works with us. We have exercise physiologists who actually does an assessment on our patients and then give an exercise prescription to them. We follow them very, very closely, and we have some nice results over the years.
Yeah, that brings up a question that was just sent to me that was asked: Are there multi-specialty clinics at Lurie that treat high cholesterol with other conditions like diabetes or weight loss and wellness? So it sounds like it's a multidisciplinary question. Do we do that?
We don't have necessarily a multidisciplinary clinic. I mean, it'd be nice to have everybody sitting at the same table. And I think that's a pipe dream that someday we will be able to achieve. But we're pretty comprehensive at this point. I mean, uh, we will take obese children with dyslipidemia. Basically, they all have some form of dyslipidemia. If you're obese, they have high triglycerides, low HDL generally. LDLs are a little bit elevated. And through working with our dietitian and working with our exercise physiologist, we can make some goals. But absolutely, we do refer quite a bit to weight and wellness to help us out with those children with extreme obesity that probably need more than what our program can do.
Okay. Another question was about optimal age for screening lipids, but it sounds like we can go and get those guidelines from the NHLBI guidelines, correct?
Yes, they're
Yeah.
all online. All I have to do is type in NHLBI guidelines. There are a whole list of guidelines that will come up.
Hmm.
You can go to the cardiology for children and adolescents,
Yeah.
reducing risk factors, and it will come up. There are a couple of varieties of it. One is a short form of it, about 47 pages. The long one is 250 pages. It's all online. You don't have to read every word of the long one. But if you want to go for the short one, it's very readable.
Well, you know what I'll do since everyone's so nice and watching this recording right now, I'll put those links right here in the comments section. All you have to do is click on that and you can go right to it if you're interested in seeing those. Another question, uh, at what lipid levels is a referral to preventative cardiology optimal? With diet and exercise changes, how quickly will the lipid levels change?
Well, it all depends. If you're FH, yeah, and this is disappointing to our families, if you have familial hypercholesterolemia, is you can optimize your lipid levels, but you're probably not going to get it down to a normal level. So anyone who's an FH really should be referred to us. I would say anyone who really has a true LDL of 130 should be sent to us. And there's also what we call the cascade effect. We always find other relatives who have no idea that they have high cholesterol. By getting a real family history, we're able to identify other family members who are at risk. In fact, one of the first studies we did is 50% of our parents did not know they had high cholesterol. We screened their children, and 11 of them wound up with lipid lowering medication because their child was screened, they were screened, and they were put on medication.
Okay. So, Dr. Rebecca Unger, who's been a great participant over these last
Okay.
few days here, has some questions in that. And she says, she asked, do you have a resource for prevention that we can include in our patient instructions, both for prevention and treatment? For example, smart phrases we can include in our EMR.
I have some smart phrases, and Rebecca, I'll be more than happy to share them with you. But we do have some pamphlets out there that I think are in PDF form, and those are open to everyone. And if they're not, I'll make sure that we open that up to anyone who needs more pamphlets on preventive cardiology.
Excellent. Thank you. We can definitely do that. And another great question. How do you get parents on board with making lifestyle changes, for example, diet? Now, I know Dr. Marma addressed this in session two. So if some of you want to go back and check out that session, you could do that. But Dr. Bennett, do you have any suggestions? I mean, you've been doing this for quite a while. I mean, I would love to hear your experience on that.
Again, I go over the low-hanging fruit. Those are sugary drinks. Those are extra treats versus snacks. Snacks is something I call it gets you from meal to meal. Those need to be more healthy. Treats is something you get a couple of times a week. Those are your cookies, candies, and we try to make a change on that. I found out in life there are three things that make food taste good: fat, sugar, and salt. In the fast food restaurants and processed foods are high in all three of those. If we could get them to perhaps cook a little bit more at home, have the child participate in the cooking. Children like to participate, we found out in cooking. If they could participate in that cooking with their parents at home, that sometimes goes a long way too. And for the whole family to work together, which I think is really important. Just because one child has FH doesn't mean the rest of the family should be eating, junk food while that child has to eat only healthy food.
Yeah. Tell you what, I appreciate you coming on today. Your expertise doesn't go unnoticed because this was a great presentation. And honestly, between you and Dr. Baptista and Dr. Ward and Dr. Marma and Dr. Gackenheimer Smith talking about preventative cardiology, I hope, I really hope our community gets a lot out of this because our kids need it, right? I mean, it's out there, and it's as you said, this is the first time that the life expectancy in our kids is shorter than their parents, and that's concerning. And so I hope people take heart of that. So if you have a child, if you have a patient that you're concerned about and you need some lipid screening or you need some other questions answered about preventive cardiology, don't hesitate to reach out to us and ask for Dr. Bennick or the rest of our folks in the cardiology program. You can use your My Chart, as you see on the screen here. Families, you can call 1-800-KIDS-DOC. Physicians, there's Lurie MD. Community physicians, or anybody watching the recording now, you can reach out to me, Chad Worley, Paula Nowak, or Julie Kalkbrenner, the liaisons for Lurie Children's, and we can help you get an appointment as well. But Dr. Bennick, thank you for joining us, and everybody online, thank you for joining us today.
Thank you for having me.
Have a great day, everybody.